Okay, round two. Name something that's not boring.
A laundry? Ooh, a book club. Computer solitaire, huh?
Ah, sorry, we were looking for Chumba Casino. That's right, ChumbaCasino.com has over 100 casino-style games. Join today and play for free for your chance to redeem some serious prizes. ChumbaCasino.com. No purchase necessary. Void where prohibited by law. 18 plus. Terms and conditions apply. See website for details.
Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thanks so much for listening. A couple housekeeping items I wanted to mention. Don't forget, if you enjoy the podcast, would like to follow it when we've got updates, new episodes, definitely track us down at reallifepharmacology.com. Subscribe there. If you do so, you also get a free 31-page PDF emailed to you with the top 200 drugs and important clinical pearls that go along with those medications. So if you're a student, young healthcare professional, definitely a no-brainer to go check that resource out. If you enjoy the podcast today, definitely leave a rating review on iTunes. That's greatly appreciated. And I think we're going to get into it. So the drug I wanted to talk about today is oral semaglutide. So semaglutide, it's a GLP-1 agonist, and there is an injectable formulation. But new to the game, within the last 6 to 12 months here, there has been an oral agent, which is the first in class. So this is a new opportunity for patients to have another alternative in managing, treating diabetes. So the brand name of oral semaglutide is Rybelsus. If you remember, the injectable formulation is Ozempic. Again, GLP-1 agonist. So this, from a mechanism of action standpoint, acts as incretin, essentially, in the body. And incretin is an important hormone that plays a role in glucose management, basically. So it increases glucose-dependent insulin release. So if you think about eating a meal, and once we eat a meal, we get that insulin release to help bring those blood sugars down, that type of thing. That's going to help oral semaglutide, or semaglutide's going to help manage that. So with that glucose-dependent insulin release, those are those postprandial, after-meal sugars. I think that's a good thing to remember. So if you've got a patient that's really struggling with those blood sugars right after meals, compared to, maybe those fasting levels are really high, semaglutide and the GLP-1 agonists in general can really target those postprandial blood sugars a little bit better than other agents. Okay. So other things mechanistically it can do, it can reduce inappropriate glucagon secretion, and it also can kind of slow down that GI tract. So, and this can, in our patients, what they may experience is a sensation of feeling more full, for example. Okay. So one pharmacokinetic property that I did want to mention in comparing Ozempic, the injectable form, versus the oral semaglutide Rybelsus is bioavailability. So dosing is much, much higher for the oral agent than it is for the injectable agent, and that's due to bioavailability. So, for example, sub-Q is approximately 90% bioavailable, and the oral formulation is only 1% or even less than 1% bioavailable. Okay, so that's why the doses are so much higher for the oral agent compared to the injectable formulation. Dosing, let's kind of stick on that for a little bit here. Oral semaglutide, so we've got 3 milligrams for 30 days, 7 milligrams for 30 days, and then we can increase to 14 milligrams per day if necessary after that 7 milligrams for 30 days. Now, very, very important to remember, and I know this is going to come up in clinical practice. The 3 milligram dose is what's considered a starting dose or a titration dose, whatever you want to call it. That 3 milligram dose is not considered to be therapeutic. Okay, so that's important to remember, because you may get discouraged if you're prescribing, if you're monitoring this medication, and that, hey, what's going on? The patient's, we started this med, patient's blood sugars didn't respond as we thought they were going to. And that's likely because we need to titrate up to the higher, more efficacious doses to actually see that response in blood sugar. So very, very important to remember that, so we don't get discouraged as clinicians, providers, nurses, pharmacists, so the patient doesn't get discouraged as well. So let's say they're checking their blood sugars and they say, hey, you know what's going on? I started this new drug, my blood sugars aren't coming down, and that might lead them down the path of, oh, well, I'm going to quit taking this. It's expensive, it's yada, 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 and it's not doing anything for my blood sugar. So definitely take the time, educate patients about the titration and that they may not see that response right away, particularly with that lower dose. So if a patient does well, A1C is under good control, blood sugar is good control, and they're at 7 milligrams, you might not push it to 14 in that situation and risk them going too low or having adverse effects or that type of thing. So definitely some clinical judgment in which dose we're going to be on, 7 milligrams versus 14 milligrams. Adverse effects, I do have another podcast on the GLP-1s kind of as a class. Really, oral semaglutide is not going to differ too much there. With that GI slowing or that gut slowing, the most common adverse effect you're going to see in clinical practice is GI. So nausea, potentially if severe enough, you could have some vomiting, maybe some diarrhea, but usually nausea is the most commonly reported adverse effect. There is a boxed warning on thyroid, certain types of thyroid tumors. So keep that in mind if you ever see a patient with that kind of past history. There can be some, enzymatic changes, lab changes in amylase and lipase. So that could happen with this drug. Rarely, there's been some case reports of pancreatitis, things like that. Hypoglycemia, certainly we really need to keep an eye out for this, especially if we've got a patient on, sulfonylurea and or insulin with this medication. One other thing in dosing and conversion I wanted to mention, you may have patients that, hey, they see this new drug, it's the same drug I'm taking, and maybe they're taking injectable semaglutide and they want to switch to oral semaglutide. I could definitely see this coming up for some patients. So conversion, so sub-Q dose of 0.5 milligrams. Package insert isn't real specific on that. There's 7 milligrams. They say convert to 7 milligrams or to 14 milligrams. So it's kind of vague as to what exactly to do. So I would look at the clinical situation. If you've got a patient that's, way out of control, their A1C is still 8, 9, 10, and they're on the injectable formulation, 0.5 milligrams, that might be a situation where, hey, maybe we'd lean towards going to that 14 milligram dose rather than the 7 milligram dose. Now, if you've got somebody with an A1C of 6, maybe they've had a history of hypoglycemia in the past, then maybe you'd get a little bit more conservative with that conversion and go to the 7 milligram dosing. And typically, I would say what's going to happen with this is you're going to start that oral dose within 7 days of that last injection. I would say most clinicians are probably going to be comfortable just giving it on the day they were supposed to take their next injection, or starting it on that day, if that makes sense. So let's take a quick break from our sponsor and we will get into drug interactions. If you're in the market for board certification study material such as NAPLEX, BCPS, ambulatory care, geriatrics, or MTM certification, definitely go check out meded101.com. We've also got free Audible books. If you've never tried an Audible book, we've got a couple of free ones available there. So you can find links to all these resources, meded101.com/store, S-T-O-R-E. Go check that out, support the sponsor, help keep this podcast free, educational, and available to all those who are trying to learn pharmacology and just become better at medication management. So with that, let's finish up on drug interactions. First two, I guess. Think about blood sugars. So we've got medications that can lower blood sugars and cause hypoglycemia. So your sulfonylureas, your insulins, I mentioned them before. The lower we drop that blood sugar with an agent like semaglutide, we can certainly run the risk of hypoglycemia. That's pretty obvious, pretty straightforward. In addition, we can have opposing effects. So drugs like corticosteroids, maybe thiazide diuretics, maybe some of the immunosuppressants like cyclosporin and tacrolimus. Those agents can raise blood sugars and potentially oppose the beneficial effects from a drug like semaglutide. As far as other drug interactions go, I would say the GLP-1 agonists as a whole are a fairly clean medication class without a ton of drug interactions. So that's definitely a good thing. I did want to mention, semaglutide and the other GLP-1s, they do slow that gut down a little bit. So that could tinker with concentrations of medications and potentially absorption rates and things like that. I think it's probably most important to think about situations where maybe we've got a really narrow therapeutic index window. So situations of, using immunosuppressants, using seizure drugs, maybe a warfarin, things that could, that gut slowing down could potentially alter concentrations a little bit. So if you've got signs of subtherapeutic levels or signs of toxicity, might not be a bad idea to check, levels of certain drugs where that's indicated and appropriate. So again, probably not a huge deal in most situations, but it is something to maybe think about and consider as you're looking at your patients clinically. All right, so I think that's going to wrap it up for today. If you enjoyed the podcast, find it helpful, definitely leave us a rating review on iTunes. Greatly appreciative when people do that. So thank you to those of you who have done that. Definitely help us out. Go subscribe at reallifepharmacology.com. We'll also help you out, get you that free 31-page PDF. Nice little study guide on some of the most important clinical pearls with each of those drugs. So go check that out. In addition, we've also got a special running on our Naplex website, rxgrad.com, where you can sign up and get basically a free 100-question practice exam. So go check that out at rxgrad.com. And you can also find that link at meded101.com/store as well. With that, I'm going to sign off for today. If you want to get in contact with me, LinkedIn is probably the best way to do so. Otherwise, you can reach out through the website, reallifepharmacology.com, or I blog at meded101.com as well. So hit the contact button. Those emails go directly to me. With that said, take care. Thank you for listening. Thank you to those of you who have left a rating and review. And I hope you have a great rest of your day.
At Baker's, shopping with pickup and delivery is the same as shopping in-store. Same low prices, deals, and rewards on the same high-quality items. It's one small click for groceries, one big win for busy families everywhere. Start your cart today at bakersplus.com. Baker's, fresh for everyone. Restrictions apply. See site for details.
Save big on your favorites with the Buy 5 or More, Save $1 each sale. Simply buy 5 or more participating items and save $1 each with your card. Baker's, fresh for everyone.
With Lucky Land Slots, you can get lucky just about anywhere.
Dearly beloved, we are gathered here today to... Has anyone seen the bride and groom?
Sorry, we're here. We were getting lucky in the limo and we lost track of time.
No, Lucky Land Casino, with cash prizes that add up quicker than a guest registry.
In that case, I pronounce you lucky.
Play for free at LuckyLandSlots.com. Daily bonuses are waiting. No purchase necessary. Void where prohibited by law. 18+. Terms and conditions apply. See website for details.